Okay, I'll try not to aspirate here. So this is a young woman whose chest radiograph came across a couple of days ago. This is, I think she's in her 30s. And, you know, her lungs are nice and clear. She does have this strange kind of replacement here of her right humerus. And she's got this bubbly lesion here in her proximal left humerus. So you looked around, and here's some views of her left humerus, showing you abnormality here involving mostly the proximal portion. And then she's got rather striking hand views. Here, this is her left hand, all the bubbly bone lesions here. So this is a bone case more than it is a chest case. And here's her right arm oncologic prosthesis here. So her humerus was removed. So she has this widespread bone abnormality, which is chondromatosis, and she'd had malignant degeneration with chondrosarcoma in her right humerus, and that's what led to this humeral replacement here. So we're just incidentally on our bone. You can see the distal part of the right humerus is was not replaced and is abnormal. So her chest imaging here is really we have the incidental findings here of the bone lesion here with malignant potential. So this is Olliers disease or enchondromatosis. And then this was, I'm sorry, this was her CT scan before the right humerus was replaced, and it shows this cartilaginous lesion at the top here with the cartilaginous kind of calcification and the rarefaction of bone. And I don't know what component of this abnormal humerus here was thought to be sarcoma rather than, perhaps it's here where things seem to be breaking out of the cortex. Maybe that was the sarcomatous degeneration of her enchondromatosis. Okay, and then wanted to show this case, and I actually have some better views of this. Let me show you this from New England Journal, because I showed a case of acupuncture with small needles left in. One of the styles of acupuncture is to leave the needles in place, and perhaps I think I should be able to mag this here. Is that going to work?
Yep.
Yeah.
Should.
So this person had, this Asian person, I think this is cases from Korea, published in the New England Journal in the last few weeks, shows this, all of these needles here, and this is gold thread acupuncture for rheumatoid arthritis. You can see that they concentrated on the wrist here, the metacarpal phalangeal joints here, and the proximal interphalangeal joints. So this is another form of acupuncture. It just came up after I showed acupuncture complication of pneumothorax a few weeks ago. There weren't any acupuncture findings on that pneumothorax case. It was just a pneumothorax ordinary. It was only the history that made it interesting. Okay, and so let's see if I can go back to where we were here. And the other case I wanted to show is this woman here who had this radiograph last summer with some low lung volumes and atelectasis in the bases, no visible abnormalities beyond that at this point. She's had some heart surgery, and her current radiograph looks more like this. And she is a person who's had a parotid cancer treated here in her neck. So she has this radiograph, shorter breath. She has some pulmonary hypertension, all of these nodules. And on CT, we find a lot of nodules here, and there's a branching pattern of some of these lesions here, sort of a tree and bud like arrangement of many of these nodules down here. She does have, clinically, she has pulmonary hypertension. Her pulmonary artery is only modestly, it's not exceeding her aortic caliber here, but she does have, clinically has pulmonary hypertension, shortness of breath, and these lesions here. So, you know, in people who are in pain and who've been getting, let me show you what MIPS look like in this case. As we increase the MIPiness here, we can bring out the tree and bud opacities here. So seeing these nice crisp lesions like this, many of them central lobular, some branching structures, and with my dismal view of people, I would assume that this was perhaps grinding up of opium-containing tablets and injection of that, and so that this I thought was going to be excipient lung, but these discrete lesions turn out to be something else. So let me show you the path on this. So this is what it is.
The right heart looks dilated there too.
Yeah, and so I mean it really does look like excipient lung to me, but instead of being you know, particles of cellulose and stuff like that from excipient, this was all tumor, intraarterial tumor. So here's an example of this tumor, and this is a squamous cancer of her left parotid, sort of an unusual cell type coming from parotid. So her vascular lesion was not excipient lung, it was tumor emboli and tumor growing in these small arterioles. And there were a few places where the tumor had broken out and was then in the alveoli, but most of the tumor was intravascular. And that would go with her pulmonary hypertension and her shortness of breath. So
now, did she have any tumor thrombotic microangiopathy, or was it all just physical obstruction from tumor?
I don't think they mentioned arteriopathy in the path report.
Because that's, yeah, because that'll give you the central lobular nodules too.
I'm sorry, what?
That will create central lobular nodules too in the context of metastatic disease, and cause similar findings. That's a beautiful path slide.
Yeah, that's a tremendous amount of cellular material. Wow.
And it's pretty discrete. It's nicely contained in the arterial, but there were a few places where it had broken through.
Wow.
Okay. All right, those are the cases I want to show.
All righty. Who wants to go next?
I want to thank Dr. Pipipath for pointing out this case to me and for pursuing the path correlation.
Great, that's a great case. You can even see the tree and bud on your photomicrograph.
But I think one of the important points, though, still is that when you have central lobular nodules in the RV in the pulmonary artery enlarged, there's a good chance it's not small airways disease.
Right.
Regardless of whether it's excipient or tumor.
Yeah.
I made a calendar made of this picture.
I got some cases if you want, Jeff.
All right.
All right, so this is a case that was brought to us by our pulmonary hypertension guys this week, and you know it's amazing here. Even though they do pretty impressive stuff, they love VQ scans. So this patient, literally everything is based on VQ scans. So this patient has multiple segmental, subsegmental filling defects, unmatched. You can see the ventilation's normal, perfusion is dramatically abnormal. And she was actually scheduled for to undergo endarterectomy. And there's one guy here that loves CT, which is good. So we got a CT on the patient. We have dual energy, but it's not worth spending the time showing you. So, there were some areas where there was this undulating appearance of the vasculature. Like here, thing gets wider and smaller. But the pronounced finding here, which was interesting, was this conglomerate soft tissue really out in the kind of infrahilar regions, extending around the pulmonary veins, and extending peripherally. This really severe septal thickening, this really impressive peribronchiolar, peribronchovascular soft tissue. There's no effusions. Right heart is severely dilated. I think the pulmonary artery pressure systolic were like 110. And I think everyone knows where this case is going. And the question for you or for people on here is, do they think that this is due to lack of filling or the underlying pathology? Because this is going to be a case of PVOD, and it nicely shows why CT is quite good. Now, I have to say this patient was sent to a major academic institution elsewhere and was not in California or anywhere where anyone here is, and was diagnosed as having chronic thromboembolic disease. which is based on CT. But anyways, I think it just goes to show the importance of getting a CT and a very nice, I think, appearance of PVOD. So 2 questions for you guys. 1, do you commonly see this conglomerate soft tissue in the perihilar regions with PVOD? And 2, do you think this filling abnormality in the vein here is related to just lack of filling because of early timing, even though there's good contrast throughout the aorta and stuff? Or do you think it's actually due to the underlying pathology? Because the pathology is obviously the venular fibrosis. It's not a fibrosis of the larger veins, from my understanding. So what do you guys think?
Well, Seth, I thought you were going to tell me that this was sarcoid and that all of this material here is sarcoid, because I showed a case several months ago of sarcoid pinching off pulmonary veins, and other people, I think you contributed a case too along those times.
Yeah, I do. I have a sarcoid venulitis. Yeah.
So I would be thinking about cancer. Like if you told me this was Kaposi sarcoma, I would say that's just fine. If you told me this was lymphoma or sarcoid, I would say great. Or even lymphangiomatosis, which we've shown, a few cases of recently. I wouldn't attribute this to some venular abnormality. There's a lot of abnormal tissue centrally here, which doesn't fit with that.
Well, David, could you make the argument, though, that because the venous system is obstructed, the fluid, for lack of a better word, needs to leave the lungs, so it goes to the lymphatic pathways, and that's why you see all this thickening along the airways?
That was my stuff, that this was all due to.
It seems to be soft, whatever the tissue is. It doesn't narrow anything.
Well, those inferior pulmonary veins look a little narrowed, at least on the right.
Well, there's
right in there.
flow coming into them because the veins are down. So I'm thinking it's all lymphatic channels that are just engorged, like in our lymphangiomatosis cases where you get dilation of the lymphatics.
Was there a biopsy, Seth? Or do we have any tissue in this case?
No. So this is understand. So the reason, and the reason why we're thinking it's probably PVOD-ish is, I know sarcoid causes issues, but I have not seen pulmonary pressures personally of 120, 130 with sarcoid without. But again, I haven't seen many very venular or kind of this venulitis pattern that you see with sarcoid. I've only seen 1 case, but her underlying symptoms and her underlying condition really is dramatically severe pulmonary hypertension, and that's how she came to us. So,
well, because they originally thought it was chronic PE, right? Based on the VQ scan.
They thought it was chronic. She was here for endarterectomy. Yeah. Literally was about to undergo endarterectomy for chronic thromboembolic disease. Now, the other thing, we did talk about sarcoid. So the other thing we did talk with our clinicians is we said, I have seen 1 case of sarcoid personally that has this striking pattern, and they're going to biopsy her. But that's interesting you brought that up, Dave. I really was much more thinking PVOD, and a sarcoid a distant second, because there's really not much, and I know you can have sarcoid without lymphadenopathy and so on and so forth. But
really interesting.
But anyways, I'll come back and once we get another answer.
Like Jeff, I too think that infrahilar intrapulmonary tissue is just waterlogged edematous lymphatic tissue.
That's what I was understanding, and I was thinking of I know Jeff showed an interesting case of lymphangiomatosis, and I never remembered the correct name. I had the one form of congenital lymphangiomatosis, but the ones I've seen, I know Jeff showed one that was different, had the more really pronounced thickening and abnormal soft tissue throughout the periphery of the mediastinum that I did not see here. But who knows?
Seth, why do you think the pulmonary arteries are not as enlarged as they typically are with, that's modestly enlarged, but for pressures.
No, I agree. The pulmonary pressures were extraordinarily high. I don't know the answer to that. She's a 30-something-year-old woman. I'm not a huge, I might be off. I think enlarged PA is a good sign of pulmonary hypertension. I don't know, and I know there's papers going one way or the other saying that the size of the PA is directly correlated with the severity of the pulmonary hypertension. It's a good marker that it's there, but it doesn't. I've seen people, and we've all seen people with relatively normal, mildly enlarged PAs with very bad pulmonary hypertension.
Right.
And to me, the right heart is, bowed in septally, has septal bowing, and
Also, Dave.
but I don't know, Dave. You could be 100% right. Sarcoid was the other thing we talked about, and they're going to send her for an open lung biopsy.
And David, to your point, usually with PVOD, the progression, the onset and progression occur fairly quickly. So there may not.
This was very rapid. This was a patient who was, for all intents and purposes, well up till like 6 months ago, 5 months ago. And this just started going downhill very quickly.
That's very.
It wasn't, she hasn't.
PVOD. And also, so I was going to say to David that there's not enough time for remodeling of the arteries to get that big for the smooth muscle remodeling. And I've seen that with PVOD. Their pulmonary arteries tend not to get very big. And she has a nice small left atrium, which also fits with it because there's reduced return to the left heart.
Okay, great
Yeah,
case.
but we're getting past. She's scheduled for open lung biopsy. But it was good because they were literally ready to do an endarterectomy on her the next day. We fortunately got them to move away with that. And I asked the CTEP guys with whether they would,
When they go in there, I hope they sample the mediastinum.
Oh, they're not going to go. They're going to do an open lung biopsy.
Yeah, but can they get some mediastinal tissue too, do you think? Or
Do you think that the open lung biopsy, if there was like sarcoid related, this venular pattern, that it would not show on that, or?
Well, I just want to make sure that we know what that tissue is medially around the bronchi.
Okay.
I'm kind of with David here, and another thought would be to do a PET to distinguish if it's actually metabolically active mediastinal tissue or if it's just waterlogged, as Howard and Jeff were saying.
That's a good idea.
Yeah.
Yeah, because we've had a couple of cases where you get pulmonary vein stenosis or occlusion from atrial fib ablation, and then they call it PVOD, which technically it is. It's just more macroscopic vein occlusion, and I'm not saying that's what this is, but there is a lot of tissue centrally there.
Yeah, no, there is, and that was the one thing we were talking about that was a little funky for us, and just a little out of the ordinary for what I'm used to seeing. I attributed it to, like Jeff and Dave were saying, just kind of, or Howard, just backlog of fluid, and somehow the lymphatics has to drain somehow, and they're all draining centrally. But, well, I'll get more, when I find out the details presented again, and I'm sure it'll be something that none of us thought about, and something we're all wrong.
Lymphoma or cocci or something.
Right. It's just going to be, it's just metastatic adenocarcinoma.
Yeah.
This was a case that we had, which was interesting because this was a guy who is a co-arc repair, and they were going to send him for a TAVI, but he had a retroaortic circumflex with a relatively low origin, so they couldn't send him for TAVI. Here's the retroaortic. And so he's had multiple valves in his time. He has a very kind of enlarged aortic root. And unfortunately, when they did the open case, you can see that somehow, or through the process, that they basically, let me just show this, knocked out his circumflex. So in the past, interestingly, his circumflex had been stented. Now the stent was there initially when they did the repair of the aortic root, because they were concerned about, not because this leads to, it's a malignant course, but they were concerned about compression at some point in time, given that his root was very dilated and he was going to have multiple surgeries. So at some point it was stented, and that's why the stent was there. But here you can see, here's this retroaortic course, separate ostium just inferior to the RCA, and then out, just completely gone. And then the unfortunate thing is he's very young, and what you can see here just very quickly is, and they knew about this. They couldn't fix it. They tried to fix it during surgery. They couldn't get into it, but it's also a very nice perfusion defect here.
Wow.
in that circ territory, and it's a big circ territory, very big circ territory. And unfortunately, after his surgery, he developed, I don't know if he's still alive, he developed diffuse cerebral edema. Not really sure why. Some people think it's cardiogenic in origin. And anyways, he had to have his back of his skull base removed for the compression because he was herniating and everything. And he's not in good shape. And I honestly don't know if he's still alive. This is from a couple of days ago, but it's a presumed iatrogenic occlusion of the circumflex. And I don't know specifically what caused it, if it was manipulation or so on and so forth, but not a good outcome. And the last case, that was just cute. Something honestly, I know you guys show it all the time. I just haven't seen that many of these. I haven't seen one in many years. It's just a pulmonary sling, but it has PE. So the patient came in with chest pain and shortness of breath and had a PE study and just happened to have a pulmonary sling as well. So
Wow.
It's a Kanne case.
So Seth,
yeah, it was just like one of those, like, oh, I haven't.
are there any?
How much is on the left side?
Yeah. What about the airways? There's a little narrowing. Are there any anomalous airways?
You know what? I didn't check.
Or cartilaginous rings of the entire, like the trachea is too small.
Just above the carina.
Yeah, no, it is narrowed, and I have a plain film too. But the trachea was more kind of, as you expect, anteriorly displaced and narrow. I just assumed the narrowing. I didn't really appreciate a complete tracheal ring on this, but it may be there bronchoscopically.
Or it's just malacia in that area.
Yeah, I thought it was just malacia from being squished right around that point. But
that's
I just haven't
that's really cool.
sling in probably a couple of years. And then here's a nice lateral radiograph, which to me, I think I would read as, unfortunately, knowing it's there, I'd pick it up, but I think that could be difficult if you're
Agreed.
here.
Agreed.
The interesting thing on the lateral view is it looks as if he's got a big right pulmonary artery. And I was looking at another case last week and stuff like that. It also looked as if you saw a big right pulmonary artery here in front of the left main bronchus in that right hilum. So,
do you think that's the interposition of the two arteries?
Yeah, I think we're seeing more than just the right pulmonary artery. I think
Right, that's what I'm saying. So if you do a MIP
where
here,
it bends around or something.
yeah. So I think if you do like a thick MIP. Anyways, I think what you're seeing is maybe a summation of shadows of both the left and right. But anyways, that was a cute little case. That's what I got.
All right. Travis.
All right, you guys see a radiograph? Röntgenogram?
Yep.
So this is one that came in this week, and I think we'd all agree on a couple of things. There's generous size heart, and there are findings, a little bit of interstitial edema. I think you see a few little curly lines, probably small effusions here, just based on this portable. This old shot pellet in his anterior chest wall is really unrelated. But as everybody does, he got a PE study because he's been having worsening dyspnea. What's interesting in this case, a little bit of history that comes into play, which we didn't know until later, but he had a outside admission a couple months ago for strep pneumonia, bacteremia, and apparently strep pneumonia meningitis as well. And he has no PE here. And I'm just going to go show you the heart. So his heart his LV is dilated, it's hypertrophied as well. And I know I've shown cases, and one of the most important places to look, and one of the easiest places to overlook, but if you know that there shouldn't be anything between the LV outflow tract and the left atrium, is you can pick up on subtle things like this. So overnight, of course, the resident just said there was heart failure and edema, which I agree with, but then I saw this in the morning and they hadn't gotten an echo yet, and I was worried this was a little aortic root abscess slash pseudoaneurysm, whatever you want to call it. And it's right below the non-coronary cusp. And he has big coronaries as well. But, you know, this is in that area of the mitral aortic intervalvular fibrosa, which is the portion of the aortic root that is the most susceptible to injury or infection, especially post-op, just because it's relatively avascular, which, you know, and then they, on exam, they did say that they heard a holodiastolic murmur from regurgitation, what they thought, which kind of explains why his LV is dilated and everything. But they did go to echo and did confirm that this was a little pseudoaneurysm, what they thought may be an old abscess cavity. He hasn't gone to surgery yet, but the ID note here is they're saying that they thought that it was partially treated, perhaps partially treated endocarditis, because he received some treatment for his strep, bacteremia, and meningitis, but then left AMA before completing his thing a couple months ago. So
they're calling it a dissection flap too, which is interesting. I wouldn't.
Yeah, I don't know about that. But
no, but
yeah,
you saw in the echo report. Yeah, they said
no,
like
I know.
I would.
So
Yeah, I agree. That's.
So
yeah.
What's the treatment, Travis? Will they have to go in on this thing, or will they?
They will. Yes, they will go in. I think they're going to have to replace his valve and repair his root because, yeah, and I know I've shown a couple of these both in the post-op and native state because these can get very large too. These little pseudoaneurysms in this area. So, but I think I encourage everybody to look at this area too, because you shouldn't see anything between the LV outflow tract and the left atrium except for a thin little wall. So, and it kind of extends even a little bit more inferiorly here. But it's also my, like, always look at the heart to explain why somebody has pulmonary edema in a case like this too. So I thought this was a cute case.
Yeah.
Very instructive. This one I'll show really quick just because David, I saw this a couple weeks ago and I was going to show it anyway after you showed yours because I hadn't encountered one in a year or more. Mm-hmm. And this was an Asian woman too. We have no history. I don't know how much of this is actually done in California, if it's all done in Asia. What's your experience? Because these, of course, look like little acupuncture needles that have been retained in her subcutaneous tissues.
There was a lot of it done in San Francisco, so very common. And so
back in your day here?
Yeah, she's got back pain, and they're treating her back pain. And so the nice distribution of these needles shows why the patient I showed a few weeks ago got a pneumothorax, because placing these needles, if somebody's not fat,
right,
you're not that far away from the pleura.
Yeah, this lady had a little bit more padding.
Yeah.
So, yeah, but I just wanted to show that as a quick correlate to yours. All right.
Nice.
Maybe we should take your case, combine it with mine, and say, look, here are the needles and stuff like that, and there's the pneumothorax.
Huh. I wish. Two more really quick cases. This is an old radiograph that actually has nothing to do with his presentation. So this is a patient that presented to the VA, and you can kind of see that I'm cheating here with the images over here. But he was referred to the VA. He's middle-aged and had a few months of B symptoms, weight loss, cough, some night sweats. And at the outside hospital, this study, they said there was bulky lymphadenopathy and a bunch of nodules, which, I would agree are in a perilymphatic distribution. There's certainly more in the lower lobes, and they're kind of ill-defined nodules. Some of them are solid with a little bit of surrounding ground glass, like little halos. The working diagnosis when he was transferred was sarcoid. I think all of us would disagree with that for a few reasons. Usually with sarcoid, you don't get lower attenuation, questionably necrotic lymphadenopathy. It really is a little asymmetric too. It doesn't really involve the right hilum as much. And I was also nervous a little bit about this asymmetric bronchial wall thickening leading into the left lower lobe, and the fact that there's a cavity, which would be pretty unusual for sarcoid.
Yep.
So we kind of steered them away from sarcoid, steered them towards either some sort of cancer. I thought maybe adenocarcinoma or some sort of infection. And they went in and did a bronch, and this is the images the pulmonologist was excited to show me, which I've now learned and done a little research on. So this is a spherule, and this is an Ant Mini for cocci. When you see this, here's another one. and then just on the stain. Now, this is probably just artifact and crush artifact in preparation. But I did see this, there's this link, which, Howard, this is from Utah, I guess, but this shows a spherule spilling open and how all the little cocci spores get out. So, yeah, and this is from I just grabbed this somewhere off of the Utah library, but I thought that was kind of cool. So, Jeff, this is for you, since you always show these nice path slides and everything, and I never get to. But this is
it's a great case.
Wow.
Hey, I show nice path slides. Come on, man.
You do. No, but not usually not infection. Yours are usually just awesome
it all
path
looks, it all looks
of
the same,
nasty
man. It
stuff.
all looks the same.
Yeah. But yeah, so this was proven cocci now. And one more, last one, another one I came across yesterday, and I absolutely love this radiograph. And I think it's a very instructive radiograph. And I'll show you. So this is an old radiograph, but I only came across it because I went digging yesterday in the chart when I read a follow-up on this patient. So I'll let you look at this for a second. Oh, stop. Let's get the PA and the lateral up here together. So what do you guys think?
Abnormal interface on that frontal projection, azigoesophageal recess should be.
I'm always curious what jumps out to people first. Yeah, and that certainly there's an abnormal interface here. You're right. Yeah, with effacement of the azigoesophageal interface. But what's really cool is take a look. You know, you think this is a tortuous aorta,
right?
But look right here. That's actually the descending aorta.
Yep.
And if you look on the lateral view, way too much here, and then it kind of spills into the azigoesophageal recess.
Yeah, you can get spine sign back there on that.
Yeah, right in here. So this is a patient who has, had at this time, a germ cell tumor with known retroperitoneal lymphadenopathy. And I'll show you, of course, you know where this is going now, but this was the PET done around that time. And you can see that this is just all bulky mediastinal, posterior, middle mediastinal lymphadenopathy, kind of giving you that extra interface there and spilling into the azigoesophageal recess here. So just a really cool radiograph, just showing that, you know, it's like a double aortic contour. But also when you see one abnormality like this, or if you see that, look for other ones. So, and then the only reason I saw this is, and like I encourage all my residents and everybody else to do, is I was reading this study yesterday, and this was a follow-up. He had actually had a right upper lobe adenocarcinoma that had been wedged out, and it was staging for that. And I just noticed this, like this abnormal soft tissue here along the descending aorta, and that's when I went digging in his chart and found that he'd had this prior lymphadenopathy and found this radiograph. So wanted to share that. All right.
Yeah, very nice.
Jeff, that's it for me.
All right, who's up next?
I can show two nice cases. All right. Okay, this is a really nice case of acute aortic syndrome, and it's going to show a bunch of findings we've all seen before, but very instructive though. So let's go from above down. And this is from the outside. They did not do a non-enhanced series. They just did straightforward CTA. So here we see pathology related to the wall of the carotid. Here we see more of it, but we also see pathology related to the wall of the innominate. And then just to go fast here, you can see there's a lot of abnormality all the way down to the root of the aorta, consistent with IMH, extending to involve the brachiocephalic vessels. Here is a nice example of the location of a breach. So let's see if I can make this one as an arrow. But here is a point of intimal breach where we can see contrast medium exiting the aortic lumen into the wall of the aorta in that location. There is mediastinal hemorrhage. We can see that there is involvement of the pulmonary artery, which we've seen before there. And then a nice example of here and here, retrograde dissection of blood into the left pulmonary artery and the left upper lobe pulmonary artery into the lung. So really a lot of nice features of IMH primarily, but with intimal breach. No hemopericardium though.
Do you think it's really
But-
intramural hematoma, or do you think it's just not incomplete filling of that aorta because your tear is so distal there?
Yeah, that's a good question. I don't know. This is all very opaque. I think it's probably intramural hematoma rather than a false lumen there. Although that's a good question. You know, this contrast here, at least at this period of time, doesn't go beyond just here. It kind of pulls in one area. But that's what I was thinking.
Yeah, I would have called it just not just thrombosed or non-opacified false lumen, but who knows? It's pretty much the same thing.
Yeah, I mean, it doesn't really matter in terms of.
Yeah, but I agree
Doesn't
that
matter.
they're all over the place.
Well,
But the way it goes up here without an intermedial flap is, again, very consistent with blood in the wall of these vessels, right? And going
That's true.
superiorly.
And it goes all the way around the right brachiocephalic. Suggesting
Yeah, circumferentially.
right there on that end.
but it's very eccentric though in the ascending aorta, and that's why I think there is a false channel, and I think there's intramural hematoma that's dissecting widely. But the main lesion here is a aortic dissection, and the reason that you don't have more contrast filling of the descending aorta is because there's not a good reentry point to establish flow.
Yeah, hard to say. It doesn't actually matter, but I think that it's got features of both. And we've certainly shown examples of a patient with dominant intramural hematoma with small breaches of intima, at least as shown on the CT.
So, Howard, will this person get an operation?
Yes, did have the usual operation.
Good.
And I don't have a copy of the op report, but they did actually perceive this breach here and the bulge. And they noticed that on the op report and they replaced this whole area. Yep, they did operate on this patient. Yep. All right, let me show you this interesting case here. So this is a nice complement to the case that Seth showed, as well as one that Travis showed, as well as one that Jeff showed quite recently. So a patient with scleroderma, let me bring up the clinical information that I have here. So I put some information there, but you can see some cardiac cath data there. So a big heart, and let me show you the non-enhanced series that she had. There are similar features on the contrast enhanced, but I want to show you the thin cuts of the more recent, which is this. So let me just go quickly down here. And what I think is really striking about this case is that down here, we see two dominant findings. One is interstitial edema. We see septal lines, subpleural edema related to the fissures. We see peribronchial fluid cuffs, right more than left, but interstitial edema. And then in the background, we have centrilobular nodules. So now I'll go uphill to the upper lungs and you'll see how florid these centrilobular nodules are up here. So a lot of interstitial edema lower down and centrilobular nodules up here. This patient does have, as you saw, pulmonary hypertension, does have pericardial fluid, and as I mentioned, does have scleroderma. So I think that these findings here are very consistent with PVOD and capillary hemangiomatosis. So I went looking for case reports of both simultaneously. So here's like one example. And these people postulate that in a lot of patients, the PVOD precedes the development of the pulmonary capillary hemangiomatosis. And I think that this case presumptively is exactly that. And one can find isolated case reports of PVOD in patients with scleroderma. So I think that a strong presumptive diagnosis is that this person has exactly that as this phenomenon. What do you guys think?
It's a good look for it, and You know, it's always challenging because we've had cases of pulmonary hypertension where they get these central lobular, especially in the setting of connective tissue disease, where they get these central lobular ground glass nodules that may be just part of the arteropathy and not necessarily the PCH component, but hard to tell because there's so much overlap. But I like it because it has the pericardial effusion, the lymph node enlargement, the pleural and lymphatic stuff you showed in a small left atrium.
And
So,
a small right fusion.
Yeah.
so is the pericardial effusion part of PVOD or PCH?
No, I think that's probably just associated with scleroderma
Oh,
and pulmonary hypertension.
Do you think
and-
the
Go ahead.
pericardial effusion could be leading to the septal edema?
No.
So there's a lot of literature on pericardial effusions in group 1 pulmonary arterial hypertension. And when you have a pericardial effusion of moderate or large volume, it correlates with a worse prognosis, especially in scleroderma patients with pulmonary arterial hypertension. So it's always something that's important to describe and try to at least semi-quantitate. But yeah, in terms of like it being just group 1 versus PVOD, PCH, I don't know.
So, but my question is, if you didn't have the septal edema, would you invoke PCH or PVOD? PVOD is what I meant.
I think without the findings of interstitial edema and pleural fluid, I wouldn't ordinarily think of PVOD. These nodules here are so profuse and in a sense so discrete that I would be a little concerned about ascribing them only to the so-called neovascularity of severe pulmonary hypertension. But because I've never seen one produce such an extensive pattern of ground glass opacity and centrilobular nodules. That is just severe pulmonary hypertension itself. But I suppose one couldn't say for sure though, because we've shown cases here before with similar findings, right? So this is certainly presumptive, but I think the combination of the two findings and the fact that it's has been described as occurring simultaneously, I think is strong presumptive evidence of it, I think.
Okay.
I don't know how many of these patients actually had scleroderma or connective tissue disease. But these are the guys that conclude that they think that pulmonary capillary hemangiomatosis may be a reactive form of angioproliferative disease in patients with PVOD. Okay, Jeff, those are mine.
All righty. I've got a few I can show. So this was a nice case we had. Hold on, let me make sure we're showing the right screen. So this is a child that has Alagille Syndrome. It's French. And here's a paper on this. And this is just a nice review article. It's old but still relevant. And they have a very specific characteristic face, large forehead, stuff like that. They get a bunch of anomalies. But
Does
one of
anyone else see your image? I don't see it. Does anyone else see it?
I see blackness.
so
I see that.
do you see it now?
Now I see your database screen with the.
You see the database screen?
Yep.
Yeah.
Okay, because it's. How about now?
Database.
Now we're getting somewhere.
Do you see a PDF?
Yeah, we got it.
Yes.
All right. So Alagille syndrome here, and you can see there's a bunch of anomalies, face things. They get cardiovascular. One of the big things they get is a cholestasis. They have liver problems, which is how many of them present early in childhood. And some other stuff. But I have a case here. I'm going to show the vasculature. So they did a MRA. Now hold on. Let's make sure it actually you can see the MRA now. So you should see an MRA. Do you?
Mm-hmm.
Yep.
Okay. So what they get is they can get pulmonary arterial hypoplasia as well as stenoses. And you'll notice, so here we follow up the main PA. There's aorta. And there's the right pulmonary artery, and it's tiny. And then the left one, you can see there's some stenoses, like the origin of the upper lobe is very small. You follow it down, and it's normal there. I'll see if I make a MIP of this. There we go. But you can see just how hypoplastic they are. So that's one of the problems with them. And they can angioplasty them open. This is just a delayed image here showing some filling, but you can see these small pulmonaries. I think I showed one of these many years ago, but it was a nice new case. And the child has the characteristic face and also has the cholestasis, which I didn't show in this case, but one of the problems with it. So Alagille Syndrome, that was given to me by Chris Francois. Now this is an interesting case for many, many reasons. So let me start with the radiograph. And you should see a PA radiograph, Röntgengram. Yep. So this is a 51-year-old guy who came into the ED with a cough and fever and sort of some constitutional symptoms. And this was his radiograph. And we've got the collapsed left lung shift, so suggesting some obstructive phenomenon. And another interesting finding is there's this pleural reflection here on the right, and then some stuff here in the right upper lobe. So he got a CT scan, and it showed lots of badness here. We've got what looks like airway-centered nodules, consolidation, necrotic-looking left lung, and then the left main bronchus just sort of dies out here. I thought I had the soft tissue images, but apparently I failed to load them. But what else is interesting is he's got exuberant pleural plaque. And he's only 51, so you wonder, how does someone 51 see enough asbestos? So it turns out he works in mold and asbestos abatement, or worked, I should say. The question is, of course, he claims in the note that he wore a mask and the appropriate clothing, and you would think in the 21st century in the United States that people are not doing asbestos removal without appropriate gear and all the fancy tents and warning signs. But clearly, we're obviously worried about lung cancer. He did have a smoking history. This looked like a necrotizing infection from obstruction, obviously worried about a large endobronchial tumor. This is, let's see, whoops, there we go. It does not wish to load. So this is an endobronchial lesion. So they went in there to biopsy it and also to try to debulk it. And unfortunately, the patient had a cardiac arrest. And then I've got, this is a postmortem radiograph. And what you can see is this is the shifted lung. And we believe this is the lower lobe pulmonary artery interlobar. This is gas in the right ventricle here, and there's gas in the main PA. So the thought is he had when they opened up the tumor, there was a communication with the artery. And so this was a fistula with a massive air embolus to the lungs. And this is just because this is collapsed right lung here. And this was a squamous cell cancer. But, it is one of the complications of debulking an obstructing tumor is that you can, if there's non-viable tissue, you can erode into the arterial or venous system and result in an embolus. But I liked it for a couple of reasons because of the, sort of the fact that he's only 51 and has this much plaque and the history that goes with it. And then just being able to see the gas in the pulmonary arterial system on the postmortem radiograph. Wow. I don't know, David and Howard, have you guys seen that much plaque in a 50-year-old?
Not usually.
Yeah, I mean, usually the ones I see are in their 80s that worked in a shipyard or something, but it was pretty exuberant plaque.
Holy cow.
Yeah, so he probably started doing this in his 20s, you would think. Okay, here's a fun case. This is something I like to show a lot. So this is a congenital case. Do you guys see a CT?
Yep.
This is an 18-year-old who presents with a spontaneous pneumothorax that won't resolve. And the diagnosis is no dilemma here, but it's a very, very large CPAM that occupies an inch, and I'll go into the anatomy a little bit, but you see this large CPAM, which is the cause of his pneumothorax. I presume he's coughing or something. And like any good CPAM, it has bronchial atresia associated with it. And of course, Travis is going to ask me, where's the law of Kanne? And it's unrelated, but there is an aberrant subclavian artery. But embryologically, there would be no relationship between the two. What's interesting about it is you'll notice there's an anterior and an apical segment of the right upper lobe. So this atretic segment is presumably a posterior segment. So this occupies, there's a fissure here. So this occupies the posterior segment of the right upper lobe. But there's also a portion of the CPAM that seems to be separate from that, and that can happen sometimes. And the way I think about the CPAM is it's sort of like the kidney. You have the airway bud meeting the, I don't know if you want to call it mesenchyme or proto-lung, And when they meet together, you get a nice happy lung growing. But when they don't, you get the sort of the equivalent of a multicystic dysplastic kidney. And so as these lung buds happen, some areas don't form normally. But it also interestingly extends down into the lower lobe and involves the superior segment. You can see it's separated from the basal segments by this fissure. So it has some anomalous fissures. So from a surgical management, I think he's going to end up with a superior segmentectomy and a posterior segmentectomy, so sort of a bisegmentectomy. And there's the bronchial atresia going with it. But I don't think I've ever seen as a matter of fact, I don't recall seeing a CPAM that caused pneumothorax before. And this is probably the biggest CPAM I've ever seen in an adult.
Do you have coronal on this one, Jeff? That would be cool.
I do, and I can make one as well. There you go.
Look at that.
Yeah.
It's interesting how the fissures are there, how it's partially, you can see it's clearly separated from the lower lobe anteriorly, but as you go posteriorly, it just kind of blurs together. So it's going to be an interesting surgery. So the question is this something that needs to be done open, or can you attempt it thoracoscopically?
Yeah.
And I think
Jeff, do you have the presenting radiograph? Did the rest of the normal lung collapse, but that stuff stayed aerated?
Well, unfortunately, I only have one with a drain already in. It was transferred, so I don't have a good one. So I didn't save it because it looks like this.
Sure.
But you'd wonder about that, yeah, because this lung won't collapse down.
Jeff will pay you to go, disconnect the drain so that he gets his pneumothorax back, and we can answer Travis's question.
All right. Well, you know what? We could always get a snapshot in the OR when they drop the lung.
Get a med student to do it.
All right, and this one David's going to like. So I'm going to go back in time to 2001. You should see a Röntgengram, or actually this is a radiograph that's been scanned, I think. And obviously a gorgeous case of pneumoconiosis. Starting to get, I don't know if I'd quite call a large opacity or if it would just be sort of coalescence, but it's really starting to think about it. And this is a guy who worked as a sandblaster. So let's fast forward to this past weekend.
How old was he at this point?
I can't remember. He's pretty old now. He worked for his 40 years. I think he's in his 70s. So he would have been about 2000. Yeah. So he would have been 50. So he'd already been sandblasting at that point for 20 plus years. And so you can see he's developed progressive massive fibrosis. We clearly have the large opacities, and you can see the background. What's striking about it is, and he developed this pneumothorax spontaneously, so that I can't explain. The only thing I can think of is this parasicatricial emphysema, one of these bullae ruptured, and because these lungs are stiff, it just didn't re-expand. But, Chris Meyer and I were talking this morning, because I'd asked him, how often do you see this dense of calcification in pneumoconial nodules? And honestly, our answer is very few. The only other time I've ever seen this was in a sandblaster.
Right. I've got one too. It was a sandblaster, and it has calcification of the pneumocardiotic nodules, which is CN,
right,
in the little check box.
I don't think I've ever taken that box to read, ever.
Yeah. Okay, this is amazing.
Yeah, I knew you'd like this case, and I got a CT just for fun, which shows the perilymphatic distribution and the large opacities. And you can see that, wow. And this actually illustrates nicely that these large opacities truly form from coalescence of the small nodules, because you can see all these little discrete calcified nodules in the large opacity. And sure, there's fibrous tissue mixed in there.
Got it.
Amazing.
Amazing.
Yeah. And
it looks like a satellite image of the United States at night.
It does.
They show the lights in the cities.
Look at the pleural surface. You can see why you get those pseudoplaques. You can see the silicotic nodules along the pleural interfaces as well. It is gorgeous. He's got the eggshell, sort of an eggshell and bonus calcification there. I mean, the history.
Jeff, does he have nodes, calcified nodes in his upper abdomen too?
I didn't look, but let's see. No, that's all vascular. Oh, nope, he does. He does.
Is that typical?
I've not seen that, but I would have to defer to David and Howard.
Yeah, David, why do you ask that question?
Well, they swallow the dust, and so it gets into the GI tract, and then it seems to me that if, lymphatics are going to collect it too, and so you could get abdominal calcifications and abdominal node involvement. Well, I agree that nodal and non-arterial calcification we're seeing, I think it's nodal.
Yeah, I mean, that's around the pancreatic head there. Then look at the pattern of it. That's not a vascular pattern. But
Right.
David, I would think silica's not water soluble, so you'd figure it would just—it's like eating sand; it would just pass through the GI tract.
Well, but I think, you know, if it would get picked up, I think, by some macrophages and stuff like that.
Okay.
You know, so I mean, you've got it here.
Yeah, I guess you couldn't argue with that. It's right in the right drainage of the proximal GI tract, going right towards the liver. I've never noticed that before. There's some nice pseudoplaques too. It has all the good features. But yeah, this was a good one I thought you'd like.
Indeed.
All righty. Well, that is it. And it is 3 o'clock Central Time. So thanks, everyone. And
Great cases,
Thank
great
you.
discussion.
That's a beautiful case of silica, man. That's really nice.
I'll send it out hopefully the next day or so.
Yeah, that's pretty.
Enjoy it. But I was glad to find a
Okay,
photograph from 17 years ago so you can see the natural history of it too.
Yeah, no, that's what's great about it.
There's
That
nothing-
progression is awesome.
There's nothing in between, but it's still cool.
Yeah.
All right.
Thank you.
Talk to you next week.
Take care.
Bye.